So Nancy, you had significant experience in COVID-related real-world research in your time at IQVIA, and where you hold the title of Chief Scientific Officer Emerita. What learnings came from that work that you initiated there that help us better understand how patients can play a greater role in real-world evidence research?
Well, I'd like to answer that question in terms of both patients and health systems. Let me
Okay.
just start talking about the state of Israel and this very interesting collaboration they had with Pfizer. In his book Moonshot, Pfizer's president Albert Bourla, says it's the greatest scientific tool the world has had for studying COVID and vaccines. But he's got the proof points, so they used a very large national health record system to study the vaccines as they entered the marketplace, and they traced the variants of COVID as they came, so they could not just say this is safe and effective against the Delta variant, but they can evaluate each variant as it came along. It was a living laboratory, and they say that in the first 100 days of the pandemic, this rapid information cycle both was useful in encouraging or resulted in a high vaccination rate in Israel. And they calculate in the first 100 days, they saved close to 6,000 lives. That's
Mm.
close to 6,000 deaths prevented by this information. I think that's pretty cool. But that's a health record story, and that's an evidence hub story where we used real world evidence and brought in external data about the variants and introduced new treatments. But I had the fun and the scientific excitement of doing direct to patient type of research on COVID. So these weren't patients, so I like to call it person generated health data or community based research. But when the pandemic hit, as you know, there were lots of big trials, there were lots of studies about hospitalizations, but we were wondering, what about everybody else who isn't in the hospital? And
Mhm.
why are some people getting very sick and some people seem to be exposed to COVID and they barely have a sniffle? Uh,
Mhm.
you know, I wondered, maybe it was a vitamin they're taking,
Mhm.
maybe it was something that we don't know about that doesn't readily appear in a health record. So
Mhm.
we launched a community-based research program where we built a registry of about 33,000 people who contributed information about their COVID exposures, the testing, whether or not they got vaccinated, any positive tests after vaccine, the reactions to the vaccine. So I think the power of this kind of information is using our communities and our neighbors to tell each other, this was my experience. So, I wasn't very sick, or I was sick for a day. And that big hope, since I'm sure you're wondering about this, but that big hope, was it, vitamin D? No, it
Mhm.
wasn't. We weren't able to find yet. I don't think the 33,000 or our follow-up was long enough to really figure out that secret sauce. And maybe we just weren't collecting the right data. But we're starting to appreciate how much we can learn from community reporters without the interface of a clinician, which was so important during the pandemic when all our healthcare workers were just exhausted from working round the clock. And the question is, how could we not further burden them? Now, you can't do everything directly to patients. You often want clinical validation, but it's usually of selected events. And sometimes you can get it from an electronic medical record with the patient's help. So I think we're going to see a whole lot more of this type of research.
Mhm. And so in your projects that you're working on now, have you changed how you are bringing in this community-based information? Is there something that you might have previously not included that perspective, but based on your experience with COVID, you are more of an advocate of that?
Well, I based this COVID research on work that I had done in collaboration with the European Medicines Agency a dozen years ago.
Mm.
So they were interested in, could you study um, the risks of medications taken in the first trimester of pregnancy, because that's something that's very hard to study from existing records, because women don't generally come in to see their OB in the first trimester of pregnancy. What I learned from that is we asked too many questions and
Mhm.
people dropped out, especially when it's just a volunteer basis. What I learned from the COVID research is we still ask too many questions. And I
Mm.
also learned that um, community reporters are getting very sophisticated. It
Mm.
was an interesting transition during the pandemic. In the beginning, you could put advertisements on the internet through social media and get lots and lots of volunteers. And as we got more sophisticated in our research questions, we could be very specific. Have you tested positive in the last 7 days? Was this your first COVID episode? All those kinds of questions. But as the epidemic progressed, people were realizing that their information was valuable. And this
Mhm.
is my same experience with EMA a dozen years ago when we went and tried to do focus groups and, among people who didn't participate, what would it take? Everyone said, I would do it for the good of mankind. But if you gave me a little consideration, I'd do it. I really do it, because they say you pay clinicians, you pay your healthcare professionals. How about recognizing the value of what I give you?
Mhm.
So I did do one small community-based study where we paid a very modest reimbursement for follow-up, and I think I got 4 or 5 times more follow-up, higher follow-up rates with a small inducement. So it's a more sophisticated market. But the big excitement, Patty, I think, is in digital health technologies. That's the new rage, and I would love to have the opportunity to study some of these passive monitors, these wearables that measure, that use actigraphy to create endpoints based on movement, even very fine movement patterns. And they're doing some very exciting work now where, in Parkinson's, for example, if you haven't heard of the study Watch-PD, they use an Apple Watch to starting to develop markers of early impairment, even among people who haven't been diagnosed with Parkinson's yet. So imagine, on the one hand, the fright of knowing that you have this early impairment, or maybe the reassurance of knowing that you don't, despite your fears. But if
Mhm.
you do have that, it gives patients the choice of how they want to spend their time and what they want to do. And it
Mhm.
gives them some measurement of trajectory. So it's a big deal.
Mhm. That is such an exciting it's such an exciting progress that is happening in the area, and it makes me wonder if patients, as you say, are starting to better understand the value of what they have to offer. I think in general, community members, through the internet and all of the advertising that happens, that they understand that they are the source of the income for these larger companies, and recognize that their existence can be monetarily recognized.
And this
And
isn't
so,
this isn't going to be like selling blood, where you can do this frequently. It'll keep you off the streets and stuff. These are generally modest reimbursements, unless you come in and donate biologic samples and the like. So just want to
mhm.
keep it in perspective.